Hello everyone, I'm Dr. Sri Banerjee, core faculty for College of Health Sciences and Public Policy at Walden University with a joint faculty appointment at Ross University School of Medicine, and currently I'm going to be talking about migraines and headaches. These are very, who hasn't had a headache? Bottom line, we all have experienced this, and to find a systematic way to, first of all, differentiate between a common headache and an actual migraine, and then furthermore trying to figure out what type of migraine you have is quite a challenge. And so when you're first starting to understand and diagnose, it can be quite daunting and overwhelming. So I'm going to give you some pointers if you're going to see patients with migraines, or if you even want to do research in understanding this condition. It would be beneficial to go to this presentation. So the reason I'm doing this presentation at this point is because it's actually National Migraine Awareness Week, and that runs from September 5 to 14. Although it started in the United Kingdom, more and more people are actually trying this, and so it's considered the third most prevalent condition in the world, and that's very important. One of the reasons that I'm actually talking about this is because it's so common. Typically 18%, and I have this flipped, 18% of women experience migraines and 6% of men experience migraines. So 18% women within the United States population. You can have migraine without aura, which is considered complicated migraine, or the common migraines, or migraines with aura. But then menstrual migraines or period migraines, these are pretty common as well. And sometimes you take a dose of Midol and some sort of NSAID, and that resolves the issue. But if you're thinking about other types of migraines, they can get pretty complicated pretty fast. First of all, how do you even diagnose a silent migraine? This is very difficult. Migraine without head pain, but then you have all the symptoms of having an aura and a prodrome and different things. I'm going to be going over the symptomology and the evolution of symptoms as you experience a migraine in a second. But before that, let me go over the other types. So hemiplegic migraine, you might have some paralysis. Retinal migraine, which is experienced in women of childbearing age, and it's blindness that can last from anywhere from a minute to a month. And that particularly is a disturbing type of migraine. I would not wish it on anybody. Chronic migraines are very difficult to deal with. Ice pick headaches definitely doesn't sound fun. Cluster headaches, these are considered excruciatingly painful, and they're also known as suicide headaches. People have actually committed suicide over these. And then we end with cervicogenic headaches, and that means when you think of cervicogenic, we're talking about the cervical spine, which is in the back of your neck, and there might be lesions in there, and movement of these lesions are creating some sort of headache. So like I said, I was going to go over this prodrome. There's some of the symptoms that you start to experience, and these may be, if you start to recognize these early on, the earlier you can recognize it, the more things you can do acutely to try to prevent from occurring. So you have a prodrome, an aura, attack, and then a postdrome. And this is often the fact for many neurological conditions. Even seizures behave this way. What are some of the symptoms? Well, you get a dull, throbbing, or severe pulsing headache, sensitivity to light, nausea, fatigue, and dizziness. What's the pathophysiology of this? Well, current theories, and there are multiple, but one of them is the activation of the trigeminal nerve. This nerve is actually the largest nerve within the cranium. There's 12 of them. but cranial number 5 is in fact the largest. And one other thing that is unique for this cranial nerve, there are some others that are like this, but it has 3 branches within the face, and then some are sensory, and then others are motor. So when you go over cranial nerves, if you're in the healthcare field, it's important to know which cranial nerve is connected with what type. So you have the optic nerve, the oculomotor nerve, all of these, and cranial nerve number 5 happens to be the one that's affected. Anyway, what are the messengers that are activating this? And so you have a release of serotonin, calcitonin gene-related peptide, and specifically the calcitonin gene-related peptide makes blood vessels in the lining of your brain swell up. And so this neurotransmitter is contributing to the inflammation and pain within the brain. So how on earth, there's so many different types of headaches. Migraines is only one category. How on earth do you differentiate? So migraines, the intensity is moderate to severe. Now, notice on the right, severe or very severe cluster headaches. Migraines can be often unilateral, but can be bilateral. Unilateral clusters are unilateral, typically around or behind one eye. Headache duration 4 to 72 hours. Tension headaches 30 minutes to 1 minute, and then 1 week. And then clusters 15 to 180 minutes. Frequency, you can't really tell. These are more migraines are more frequent than tension types. What are some of the symptoms? Well, I went over these. Sound or light sensitivity, nausea, vomiting, aggravated by physical activity, or allodynia. And that's some of these are feelings of pins and needles on the body, some sort of numbness, tingling. Demographics affects women 2 to 3 times as much. Higher prevalence in women than in men, even tension type and clusters believe affect may affect men more. This is from the article, by the way, Diagnosis and Management of Migraines in 10 Steps, and this is from a Nature article. Step number 1, when to suspect migraine. Well, if you're having a recurrent headache of moderate to severe intensity, you see the visual aura, a family history of migraine, or onset of symptoms at or around puberty, then you might want to suspect migraines. Diagnosis of migraines, record medical history, apply diagnostic criteria, consider differential diagnoses, and this is pretty common when you're writing up a patient note. Examining patient to exclude other causes, and using neuroimaging only when a secondary headache disorder is suspected. And then patient centricity and education is important. Provide appropriate reassurance, agree on realistic objectives, identify predisposing and or trigger factors, follow strategy to individualize therapy according to symptoms and needs. And a lot of this really is very similar to other neurologic conditions, such as seizure disorder, or anything that is similar. So just going through the second part of this is actually, I wrote diagnosis but because it was part of the same figure, but this is actually more acute and preventative treatment. So acute treatment, first line NSAIDs, non-steroidal anti-inflammatory drugs. Second line, triptan, sumatriptan. These work on the serotonin receptors. When triptans provide insufficient pain relief, then combine it with fast-acting NSAIDs. So there's a whole plan. And then third line medication, of course, is gepants and gepants, which stave off nausea, and the feeling of nausea. Adjunct medications for nausea and or vomiting, prokinetic antiemetics are also used. A preventative treatment that goes after, that's recommended for patients adversely affected on greater than or equal to 2 days per month with despite optimized acute therapy. So the first line medications for preventative treatment is actually beta blockers, believe it or not, and then topiramate and candesartan. Candesartan is actually an ARB, it's actually it's considered an ARB. Second line medication is flunarizine, amitriptyline, or sodium valproate. And then third line is CGRP monoclonal antibodies that targets the specific CGRP. Managing migraines in specific populations like older people or children and adolescents or women who are pregnant or breastfeeding or women with menstrual migraine. These are special populations, and in older people there's actually there's not much information about them. Also be aware in children it might present in different ways, and parents and schools have important roles in the management of young children. Bed rest alone can be sufficient, and use ibuprofen for acute treatment, and maybe propranolol, amitriptyline, or topiramate for prevention. But be careful in using too many difficult drugs. Tylenol for acute treatment, and women who are pregnant avoid preventative treatment. And then women with menstrual migraine, perimenstrual preventative therapy with long-acting NSAIDs or triptan. Then you have clinical management and follow-up evaluation of treatment response and management of failure. Use headache calendars, assess effectiveness and adverse events when outcomes are suboptimal, or review diagnosis, treatment strategy, dosing, and adherence when treatment fails. Reevaluate before changing, and then referral to specialist care should be reserved for patients whose condition is diagnostically challenging or difficult to treat. Managing complications, medication induced headache, medication overuse headaches, MOH, is something that is recognized and discouraged. And so then you want to stop established medication overuse, withdraw overused medication, preferably abruptly. Specialist referral is indicated for patients with chronic migraine, and always you have topiramate, botulinum toxin A, or CGRP monoclonal antibodies. So Botox is used in this as well for headaches in some instances. Then recognizing and managing comorbidities, and so this actually is known to be connected to cardiovascular disease. So identifying comorbid conditions, selecting drugs, and adjusting their use according to comorbidities, and alleviating comorbidities if possible to improve outcomes. Planning long-term follow-up, manage migraine long-term in primary care, repatriate patients from specialist care in a timely manner and with a comprehensive treatment plan, and then maintain stability. A lot of this really sounds like diseases which have kind of an acute phase and a chronic phase, and many chronic diseases behave like this, and it's important to get the treatment right. What is preventative therapy? Well, first line, again, NSAIDs, plus antiemetics if necessary because of the nausea. 3 consecutive attacks without treatment success, then you move on to second line medications, triptans. When suboptimal effect, consider combining with a fast-acting NSAID. 3 consecutive attacks without treatment success, then you switch to a different triptan treatment plan. Treatment failure of all available triptans, then you switch to ditan or gepants. So this is kind of the order in which everything happens in optimization. Treatment optimization has a stepwise approach in trying to achieve maximal success in treatment of migraines. What are the recommendations? And these are the ending kind of 10 recommendations. Offer acute medication to everyone who experiences migraine attacks. Advise use of acute medications early in the headache phase so whenever you're getting the prodrome phase of the attack, as effectiveness depends on timely use with the correct dose. Advise patients that frequent repeated use of acute medication risk development of medication overuse headaches. Use NSAIDs. Use NSAIDs such as diclofenac and others. Finally, some other recommendations: use triptans as second-line medication. I've already been over this in some of the other algorithms. Consider combining triptans with fast-acting NSAIDs to avert recurrent relapse. Consider dietans and gepants as third-line medications. Use prokinetic antiemetics as adjunct oral medications for nausea and or vomiting, and then avoid oral ergot, alkaloids, opioids, and barbiturates. So if you keep these in mind, then you will definitely know what to do when your next migraine attacks happen. This gives you a better understanding of all of this from a patient perspective, but not only this, when you're first learning this from a medical perspective, this is very useful and helpful, because then you can create a list of differential diagnoses based on headaches and the symptom of headache, and this is actually an expectation when you are taking some of your exams. In fact, I still remember one of my 10 patients for the Step 2 clinical skills exam had a migraine. And so the expectation was for me to kind of ask the right questions and get a good history of the migraine to be able to effectively not only diagnose, but also use proper bedside manners in order to effectively communicate with the patient. Now, these were in this exam, which lasts for a whole day. Actually are trained mock patients, but very much a reflection of what we encountered in real life. So that's kind of a ending, a little story about how all of this can be brought together to understand headaches better. So happy Migraine Awareness Week. Thank you for listening.